Awesome. Hi, everybody. I know a lot of people have already started to log in. So we'll go through some housekeeping stuff before we jump into content. First of all, just want to introduce myself quickly. My name is Brooke. I'm a speech pathologist here at Tim's Medical, and I am really honored and excited to have Dr. Bearwell back with us this evening to provide her expertise on the oral status in video fluoroscopy. And she has a wealth of knowledge to share with us tonight. So I'm super excited to have her with us this evening. A couple of housekeeping items. This session is eligible for 0.1 ASHA CEUs or 1 PDH. As always, we will record the session, so you'll be able to go back and watch this recording tomorrow when it's uploaded to the TIMS website. If you would like ASHA CEUs for attending tonight's presentation, we ask that you complete a brief survey, which I will link in the chat. It will also be sent out via email a couple of times from Zoom, so just be on the lookout for that with the webinar replay link. And then if you have questions as we go, feel free to put them in the chat or the Q&A box, and we will have a session at the end of this webinar where we open the floor for Q&A. So with that, I'll go ahead and hand over the floor to Dr. Bearwell. Thank you all for joining us.
Thank you, Brooke, for inviting me. Thank you, Tim's, and I'm glad to be back with a different topic that I hope interests everyone. I'm going to share my screen right now. Here we go. We're just going to jump right in, and I believe you can see that full screen. So like Brooke said, we're going to talk about the oral phase. We're going to talk about oral status, mastication, and swallowing performance. This is, the reason we're bringing this up is because I've spent decades as a prosthodontist, so involved in oral reconstruction. And then now in this later part of my career, I'm really focused on dysphagia. So the two are mixing together here, and I really hope it gives you some rich information about the oral phase and what these swallow studies are telling you or what we need to learn more about. So I've decided to organize a talk in 4 parts. And so first we're going to look at the oral environment itself, like the dentition, the posterior support, prostheses, the dentures that you see pretty much every day, and saliva. And we're going to talk about why the same food is not necessarily the same task in the mouth. Then I'm going to make a distinction between liquids and solids because solids are dynamic. I firmly believe, I know that on IDSE we have transitional solids, but I do believe that all solids transition in the mouth. It's just that that transitional solid does a really big transition, right? So what we know is that patients aren't just taking a ready-made bolus and transporting it in the mouth with a solid. These are foods that are changing while that patient's eating it and changes which, and then basically it changes what that pharynx ultimately experiences. And so the third section is going to be really the measurement problem. So talking about the oral processing being dynamic. And so what can we look at on the MBSS and how can it be helpful to us? And I really want to separate processing from transport and bolus state and residue and clearance in a way that hopefully will be clinically useful for you. And talk about timing as, that oral transit time, but going a little bit deeper and seeing what else we can learn. Finally, I'm going to bring in an active Cleveland Clinic study that is ongoing now with the primary investigator being Brian Hedman. And we're going to look at different questions about diagnostic yield, as well as how can we maybe codify some of these oral processing behaviors across different textures. And then finally, OraSync, which is really using the food not only as something we test in a trial, but also as a controlled challenge to help us understand a task, like food being a task, and what work that patient has to do and what work is useful, and where does that task become too much for that patient. So I'm going to play this video and, I want you guys to describe what you see. You can put stuff into the chat, but you've seen this time and time again. Partially edentulous patient missing all posterior support. And right now, they're trying to eat their bolus and you're looking at it. So my question is, what would you write in the report when you see this? What are you seeing? Um, we're seeing that prolonged processing, kind of like this irregular mastication. I can see some fragmentation happen. We see that posterior transfer, the cough, and residue. And how many swallows did that patient need? But what we can't learn from this is what the primary cause is. Is it neurologic? Is there dental issues, salivary flow, food specific issues, or is it an interaction of everything together? So I want to dig in today to this attribution problem to give you more of the information for you to understand oral behavior and have a better appreciation for the why behind what we just saw. So one thing I've heard repeatedly from clinicians is that oral component score in the MBSIMP is not always completed consistently. I mean, we can't make this fully interactive, but put in the chat, are you using that oral component score? Is it a yes or is it a no or is it sometimes? And I don't think that reflects a lack of interest in the oral phase. I think honestly that part of the issue is that what's not always clear is what those oral findings mean for the rest of the swallow and which variables may be driving what we see as in the previous swallow study. So that oral score with the MBSIMP gives us an impairment description, but it doesn't in and of itself tell us whether the limiting factor is tongue control, dentition, posterior support, prosthesis stability, saliva, food properties, or some interaction. And so that matters because the intervention should match the limiting variable. So, for example, if the problem is oral architecture, the answer may be different than if the problem is lingual control. And if the food is simply asking too much of the available system, changing the task may tell us more than assigning a more restrictive diet. So, the other thing I want to mention is that, solids and their behavior is not like liquids. And so with liquids, we're seeing more of containment and propulsion. And with a solid, the patient has to transform that food while it's in the mouth, place it, process it, gather it, lubricate it, and then transfer it. So if we want to understand solid performance, I think we need to look beyond a single impairment score and start describing the oral task in more detail. So here's a model that I created that I'd like to kind of dissect a bit. So let's just say we have to look at the patient, right? The patient enters the study and might have a neurologic condition. They might have pain, fatigue, attention issues, emotional issues, or respiratory reserve problems. And so that's one domain that influences the oral phase. The mouth brings the architecture, so it's not simply teeth, but distribution of those teeth. So we're not just counting how many teeth are in the mouth, but where are they located? Think of a three-legged stool. That's a more stable configuration than two stool legs on one side. So we do need to look at stability of the jaw and where those teeth are located because those teeth are kind of like the stool legs, right? And so distribution, occlusal stop. Occlusal stop means upper molar touching the lower molar. That's a stop. So if you have back teeth, posterior teeth, but they don't stop, they don't touch each other, then that leads to instability of the occlusion. So chewing ability, prosthesis stability, very important. Yeah, they have dentures, but how stable are they? The vertical dimension, how big are they? Are they tiny? Do they fit the mouth properly? And that actually changes their behavior. The palate, the tongue space and any surgical changes that might have happened, such as with your head and neck cancer population, changes that oral architecture. And then there's the oral processing capacity, the tongue, jaw sensation, saliva containment, and clearance. And finally, the food brings its own task. So on the MBSS, we see the output of all four. And so, this is kind of like really complex. And when we look at how this model in the mouth was described, it's the process model that, was described by Palmer. And the reference condition is for eating a solid. So he broke it down into stage one and stage two transport, stage one transport, sorry, and stage two food processing before the pharyngeal phase and then the esophageal phase. But in this model that's created, it's based on stage one is moving the food to posterior to the canines. So it's going from the anterior mouth to that region because why? Because we were all built to have greater efficiency of processing in our molars. So, and during this food processing or stage two, you've got this chewing, saliva mixing, repeated tongue repositioning onto the occlusal surface. And so it's this posterior movement. So he also describes this stage two as being like the tongue going from anterior to posterior, but in a squeeze back pattern. So it's not a transport, it's a squeeze back. Think of it as a wave. The tongue is the wave, and the bolus is in the front of that wave, and the tongue is pushing that bolus back. And this can all happen while mastication is happening. So everything is happening in a kind of like a continuous or overlapping phenomena. So here's the assumptions of the model about the oral environment. It assumes that there's somewhere useful to put the food behind the canines, and there's enough saliva to participate in bolus formation. So the question here is not whether the process model is wrong, because it's not, but what happens when that oral environment changes? So I ask that question because I know a lot of you face patients that are edentulous. They forget their dentures if they are edentulous, or they're partially dentate, or they have partial dentures, all the implants. I know you see them all. So that's the question, is that there is a high prevalence of edentulous patients in long-term hospitalized adults. And only if 31% are edentulous, but only 14% have a denture in place. And another study showed that 695 dentures were lost over 5 years. And the way they get lost is they're left on the meal trays. And so what you experience, the very moment that it matters the most, that prosthesis might be absent for the modified barium swallow. So just to understand again, that stage one has a destination, the functional posterior processing surface. So the point is that we are hardwired for efficiency. If I don't have any posterior contacts, am I going to move the food to the posterior region? And so what I see often is the social six, right? Canine to canine, canine to canine, no posterior occlusion, or completely edentulous. So will the food go back? And I'm seeing on these studies that time and time again, the food remains anterior. And what the patient's doing is not this stage two behavior, but compressing the food against the palate in the anterior zone. And I want to show you what that might look like. So here is a shortbread cookie, and you can see this behavior. Now on a lateral view, I don't know if this molar has a contact, but I'm going to say here that I assume it doesn't, because if it did, I would see contact time between this tooth and this tooth. So it might be on the opposite side. It's 2D, so I don't know if left to right. But look at the direction of the food. It's going anterior to the anterior teeth, and it's staying against the rugae of the palate because there's more friction there. So it's not a one-way posterior progression. It seems like, and take a look at this bolus. The bolus is staying in the anterior. They're trying to see when is it ready for manipulation and bringing propulsion back. And it's it's like a bidirectional oral bolus transport, right? So it's anterior to posterior and then posterior to anterior during this ongoing oral processing phase. So I'm not going to say this is impaired transport because I honestly think the tongue is adaptive and it's doing the new processing strategy. So is the tongue collecting and assessing and repositioning and reprocessing the material as sensory information changes? Um, and so that is a very interesting behavior. But again, I want to share that this is not following the classic model. And I'm sure you're seeing this happen time and time again. We also don't know if this patient doesn't have a lot of saliva. So I want to kind of separate the observation from the mechanism. And we need to just see and witness what we're doing and start asking some provocative questions about this behavior and what it actually means. So let's just go here. So basically, I want to get back to prosthodontics and just say that, when your patients present, they might present with a natural tooth. They might have implants, and you can see on this panoramic film that there's multiple implants in this patient's mouth, and this is might be what you see. You might have these implant supported prostheses in patients of yours that are actively in hospital. And so what you need to know is that these teeth have ligaments and a ton of mechanoreceptors, proprioceptors built into our tooth system. Helps us with orientation when food comes in. How much force am I going to use? Right? And so implants restore stability. This thing is rock solid. In fact, it moves less than a natural tooth. It doesn't move at all. Okay, zero movement. That means that, to be honest, force that can be exerted by someone like this is incredibly high. But they have a different type of perception. It's not ligaments, right? It's called osseoperception. And they get sensory, but it's a different type of sensory. But then take a look at this. This is the same patient. It's a patient of mine. They had all their teeth. Believe it or not, I took out all of these teeth as one piece because they had so much disease. And then we placed these dentures. And so this is an upper denture and a lower denture. But now we have no sensory. The only sensory is from the mucosa when it comes to the alveolar ridge. So we get a drop in sensory feedback. But not only that, they can't bite down as hard. So 10 to 30% of their natural chewing capacity. So this is really an underappreciated kind of thing because, when you're looking at a bolus, a trial in a person's mouth, and you have these dentures in place, you need to understand the time to process this food is going to be different from a dentate individual to edentulous, and then of course the implant supported. But then also we have the no functional posterior support. So this is a completely altered geometry. And so they are going to compensate by moving the bolus where it's most efficient. So the other thing I want to mention is something about implants, right? Because I was an implant specialist for many years, and you have different types of prostheses. And when you look at these prostheses, what I want you to know is this stays in the mouth, it never comes out, right? And cleaning can be very difficult. So hygiene can be an issue. But this is going to be rock solid in their mouth, right? So chewing efficiency is going to be higher. Bolus control, right? when something isn't moving, you have better control, but it is hard to clean. Here we have something where they might have a bar in their mouth. You can take out their denture and there'd be a bar there, and this prosthesis fits on top of it. Now, this gives them stability, but not as much stability as here, right? And then here they might have implants and just a couple, no bar. And this is non-rigid, so there's more mobility in this, right? So that you use the same chewing pressure, it's going to deform the gum tissue, and you're going to have a little bit rocking motion happening as the patient's trying to transport their bolus. So when you write in your notes that the denture is present, I think that there's characteristics of that denture as to whether it's stable and whether how well it's functioning for that patient. So the other thing I want you to realize is barium will coat the food trial, right? And you will be able to see residue patterns of that food trial after the swallow. But a prosthesis can hide residue. And you could have residue from a previous meal that is buried underneath these prostheses. And oftentimes, I'm sure you see this, you take out the denture and underneath it, it's caked on with plaque and food debris. And that debris can be quite dangerous because it has microbes in it and it's just a full flora happening underneath their denture. And this can also happen in this implant. This is implants. You can see these little holes here. The food can retain here. So you can actually, even with barium, and they're doing the barium swallow, you can see food perhaps that's just trapped there, and very difficult to remove. So the next thing I want to share with you is ridge anatomy. Because gums are not all the same. So when you lose teeth, which ridge anatomy do you think is going to support the denture the best? Which tissues do you think have the most sensory feedback, right? So like mucosa, when you lose your teeth, you lose periodontal ligament fibers, but then you have your mucosa. So, right here is someone with really great bone, right? So it's going to hold on to that denture. And so, that they can elicit more bite force, right? And it's going to stay in their mouth. Whereas this is, look at how spiny that is. So that leads to thinner tissues, more susceptible to pain, discomfort. And your patients that are not wearing their dentures are likely not these ones, but more so these ones, right? And so the other thing is most patients don't know that they need to get their dentures checked every year because when they come to the hospital and these dentures, they're like, I don't wear my dentures. I don't need to wear my dentures. But now they have dysphagia. I can tell you that they're probably not efficient chewers. Their bolus size is probably quite large at the time of swallow, right? And the tongue pressure, which we're going to get into, might be altered by this moving platform. So basically, patients have to be really good when they get to here with tongue control of the denture and cheek control of the denture. They're not thinking about it, but they need to have those to have success with dentures. And so I just ask, like, if someone has Parkinson's or post-stroke, they're going to lose some of that tongue control and cheek control of the denture itself. And then, they have dysphagia. So these are impairments that can happen with a previously fine denture beforehand. So I just want to say that, please look at the stability of your denture, whether it's stable or unstable or absent, because all of those are different oral environments. So these are different test conditions for when you do your modified barium swallow. I just thought I'd throw in this picture because I was blown away when I was in India, and this was a few years ago. But here we have someone with, if you don't have a well-fitting denture or you lose your denture, they can just give you one, throw in some reline, and off you go. And yeah, that's kind of a frightening thing. But as a dentist, I was like, I got to take that picture. So anyway, now I'm gonna butcher his name, but Imazaki did a really clever experiment, for when we want to look at the influence of teeth. So everyone in this study had a denture base. That means the pink part, right? But the investigators removed in one cohort the artificial tooth arch. So they took out all the teeth from the denture. So they could isolate this role of what I said, of the occlusal stop or occlusal support. Um, and what they noticed was with the arch, so when they had the teeth present, the masseter activity and peak tongue pressure were greater. And also, when they were doing the swallow, the mandible stayed closer to intercuspation, and the tongue pressure was better timed to laryngeal movement. So that was a really interesting study to show that the artificial arch changed more than just chewing, right? Like it changed mastication, but it changed muscle behavior, tongue pressure, mandibular stabilization, and timing relative to the laryngeal movement. And I want to share with you a little something because I think a lot of times you see patients that come in that maybe have vertical collapse. So this patient here, it's vertical collapse when they have nothing to bite against, right? But a lot of times dentures that are really old, that have never been relined, have never been remade, could be worn down and you lose vertical. And vertical is like this measure from your nose to your chin, right? Like, does that collapse? And so the question is what's the impact of that for, the world of dysphagia science, right? And so what they noticed, so studies have looked into this a lot. There's increased oral and pharyngeal residue, decreased masticatory efficiency, bolus scattering, and reduced oral sensory input. Now, the corollary is vertical dimension invasion. This happens a lot when people have implant prosthetics in their mouth. The teeth are made too big. Why? Because there's a ton of hardware underneath those teeth, and it has required dimensions for strength. And so oftentimes it's like it's a whoops. Oh, we need more space. But what happens? What happens when we make dentures too big? You change speech patterns, right? You have impaired clearance. Your tongue can't go over those teeth to clear from the vestibule the residue. You don't get that tongue sweep. You just can't do it. You can't go up, you can't go down. And you report earlier fatigue. Why do we have fatigue? Well, when your teeth are right up against each other, your jaw doesn't have a resting posture that is a normal resting posture. The muscles are always activated and you get TMJ discomfort. But they also notice interference with phonation, mastication, swallowing, and a reduced biting force. So those are two things to consider. Now, I want to talk about the lip seal because as I, learned your terminology, I was like, oh, well, we talk about this, but in a different way. And for the oral phase, what I understand is that, this anterior seal is, the lip closure is an important part because you are creating this negative pressure wave during the oral phase, right? So the lip seal helps create this negative pressure. So these lips are pressing up against the teeth and kind of sealing things off. And so this is, the question though, in this patient, they have their dentures in place, and when they swallow, they're pressing their lips against the denture teeth, right? But the question is what happens when they don't wear their dentures? How effective is that lip seal against a residual ridge with no, like, think of a fence. The teeth are the fence. There's nothing there. So the lips need the teeth to brace, and they don't have it. So the question is, does that tongue palate pressure take over in that instance? So I just want you to start thinking about things like that, because dentures restore more than just teeth and gums. They restore that labial support. They help position the lips to create a pressure resistant anterior seal. And so your support then shifts, right? If you don't have that, to the more emphasis on the tongue palate pressure, on a tightening of the orbicularis oris as the lips roll in on the residual ridge. So I just want to get us into this oral architecture is more than a tooth count. So that's what I'm hoping for this talk, is that we can say more clearly that it's the number and distribution. Do I have posterior teeth and anterior teeth? So where are those remaining teeth? Are teeth touching each other in the posterior region? Am I going to get mastication happening back there? Or is the patient just going to put all the bolus up front where they have better efficiency for processing? And so, what kind of prosthesis do we have? Is it stable, right? Is it implant supported? What's the vertical dimension like? Are things collapsed? Are they going to build more residue just because of a vertical dimension collapse? Or are they going to have difficulty swallowing, like that premorbid condition where those dentures were just too big? And so they have speech difficulties with that too. And so what surfaces are available for pressure and clearance? So really looking at that palate and the tongue space, because I can tell you a lot of dentures are often made that invade the tongue space, right? But also, if someone's not wearing dentures, the house is gone, right? So like you have a severely resorbed ridge, that tongue doesn't have a confined space to press up against. It's not just the tip, it's the whole, as that food is being propulsed back, it's the tongue, and then it's the mid dorsal surface and the posterior surface. So really, what is it pressing against, right? And so also the surgical anatomy. So I want to talk a little bit about this idea of tongue pressure, because there's been studies that go both ways, right? They say that, tongue pressure edentulous, tongue pressure dentate, it's the same, and some studies say that it's different. And so what I'd like to say is that the absolute value of tongue pressure might not be different, right? But what I think is, where is that work going? So if you have, just imagine that edentulous arch that I showed you that was severely resorbed, and you've got a denture in there and it's a floater, right? It's not stable. That person's using tongue pressure, the same 25 kilopascals as an example. Is it going to behave, is essentially, is that equivalent mechanically to 25 kilopascals with someone who's dentate, right? And so the reason I say that, it's really about, is that tongue trying to stabilize the denture and and is trying to seat the denture to prevent it from falling down. So the effectiveness of that tongue palate pressure for what we want, which is propulsion of the load, the bolus posteriorly, is it as efficient a system as a patient that is dentate? So now I want to add in saliva. Saliva is not a background moisture. It is part of the food processing system. It hydrates the matrix. It lowers friction of food against mucosa. It helps those particles aggregate, and it changes how much material sticks to oral surfaces. But the same patient can look very different depending on whether that food demands saliva. So basically, we really need to pay attention to the food type in solids and what kind of solids would demand more moisture than others. Now we can't diagnose xerostomia from an MBSS, and frankly, asking someone if they have dry mouth, that's kind of it's a partial answer because it's really not based on like exact measures of saliva, but for the most part, our evaluations come from history and a clinical evaluation that we make of the wetness in the mouth. Um, and so essentially, your MBSS is showing you the performance under that condition if they do have a dry mouth. And what I can say is that we can restore the medium, right? We can have salivary management or salivary substitutes where appropriate, sauces where appropriate. You can create a more wet environment, or there's hydration and moisture that you can provide, right? So making sure they're totally hydrated. What's interesting is that the clinical evidence that saliva substitutes can improve subjective swallowing measures and swallow and water swallow performance. There was a systematic review, and they concluded that their effects on actual food bolus rheology and oral processing remain inadequately studied. So, the other thing I want you to know is that dentures require saliva for retention. So if you see a denture that's moving around, person's complaining of dry mouth, it might not be that that denture is ill-fitting or their jaw, their bone is resorbed. It could also be the fact that they don't have enough saliva to hold that denture up or down in the mandible. So we need a thin film of saliva for good retention. So here is, this is a good example here of why the food task matters in xerostomia. These patients in this study had post-radiation xerostomia, but with the liquid and paste, the timing measures looked very similar to controls. And then when they gave them a dry shortbread cookie, the mastication time increased by 46%. So the dry mouth didn't become suddenly worse. The task changed with the dry cookie, and it required more hydration, lubrication, particle management. And so that's when the deficit showed up. So, so what's also important here in this study is that the pharyngeal swallow itself was not the major abnormality. The difference was in that oral preparation of the solid. So that's just the point that I want you to keep in mind. The impairment may be there, but whether you see it depends on whether what the food is asking the patient to do. So Gatto took this one step further. So what they wanted to do is they reduced salivary flow with atropine in healthy men and changed the cracker type, right? So they had a plain cracker, a cracker with high fat content, and it was unseasoned. And then they had a cracker with high fat content and seasoning, and a soft cracker. So what they were looking at is the duration for mastication, right? So then that what they saw was the duration. There was no significant increase in duration when there was fat and seasoning in the cracker, but all other test conditions, that duration increased. So basically what I want you to take from this is that xerostomia is not simply a fixed patient deficit. It's really a functional effect that depends on the food. And I've noticed that also with the food product that I make, Crispy Melts, because it has a high fat content and high seasoning. And so we are seeing this kind of better ability in dry mouth conditions than other, dissolvable products. So here, what I want to share with you is, the puree. So when we do our MBS IMP, we're doing a puree challenge and then the cookie challenge. And puree can absolutely test oral function. And we're just going to show that here. So, it's going to take a look at it's going to show you containment, tongue palate pressure, propulsion clearance, and coordination with the pharyngeal swallow. But that food is pre-processed in the sense that it's not dynamically changing in the mouth. The patient doesn't have to place it on the occlusal surface. They don't need to fracture it and or repeatedly move it laterally or combine particles with saliva. So what that trial is telling you is the patient can perform the puree task, but it doesn't tell you what happens when the mouth has to manufacture a swallow-ready bolus from a solid, right? So that conversation that we had about stage one, and it's not really challenging that either. So that's where these transitional solids come in, because they're highly variant, but in this solid foam type of transitional solid, in particular, crispy melts dissolves to an endpoint of puree. They don't all do that, but they call up a different movement repertoire, if you will. The patient will capture the food, they'll place it, process it, gather it, and transport it, right? So that's a different task demand in the oral phase. And basically, the tongue, if they have teeth, is repeatedly moving food onto and off that occlusal processing surface while that jaw is cycling. So even if it dissolves to an endpoint of puree, the behavior that it's eliciting in the mouth is going to be completely different and valuable to you to observe, versus a puree alone. So I just want to kind of go over just a review, the three levers to optimize the oral phase. So I presented all of that information to you, and it's just like, okay, now what do I do? Well, I just I want you to know that like if you notice the dentures and they're not adequate, the retention and stability is low, then, do a dental consult. Try to restore that platform because what you're going to do is reestablish mastication where you have the greatest efficiency, which is the posterior region. Um, the other thing is restoring the medium. This talk isn't about salivary management strategies. That would be a completely different lecture, but just know that like looking at foods and the types of foods that have higher wettability or don't lead to higher levels of fatigue or mastication need prolonged time. That can be something that you should start to explore. And of course, hydration and salivary management. So with the change the food task, we talked a little bit about transitional foods, but the other thing to mention is that even within each IDSI level, those foods actually have different behavior patterns. So, again, this is, we can go more in depth another time on these different food categories and how foods are actually, there's slight variations in behavior. In a recent study actually just came out with regards to this by Piazza, and they were looking at puree type foods and noticing different shear force requirements for these foods, and other measures. So just know that when you look at a functional texture, such as the transitional solid, the high dissolving solid, it's going to create different movement patterns. And so that those movement patterns might be beneficial for you to observe in the oral phase. So that just brings me to this diagnostic dilemma. So when you are looking at puree on your modified barium swallow, um, essentially the puree can look efficient because the oral system is basically not being asked to do a lot of transformation or transitioning of the solid bolus, right? Now you go to the other extreme and the cookie, like the Lorna Doone cookie, can fail because the patient might not have the posterior support. They, to fracture that product, they might have a dry mouth. They might have low endurance. Particle collection might be an issue. And pharyngeal reserve are all challenged all at the same time. So that one task may be asking too much of the patient. So so when you want to find a middle zone of where that patient's usable oral capacity lies, that missing middle question is whether a high dissolving functional texture can recruit solid-like behavior without imposing that full burden of a conventional cookie. So this is, the definition of a functional texture is a high dissolving solid that elicits bite, chew, and lingual movement, and then rapidly forms a cohesive bolus within the recommended soft diet. So the question is does that alter the demand? Does alter demand expose different capabilities? So, we're going to get some oral manipulation, mastication that you wouldn't see with puree. But the mechanical demand is lower because it dissolves quickly as it hydrates, and so the patient's not going to need to require the masticatory performance that they would with a regular cookie. So in this study that was done recently, they looked at three textures, right? They looked at the graham cracker, which was a regular cracker, the crispy melts, which was your functional texture, and then the applesauce. And so in this study, what they did was they were using fees and they were using blind raters. And so it was a heterogeneous population in an outpatient setting. And they measured swallow safety and efficiency using VASES. So they had the functional texture trials, the majority, all of them had a PAS of 1. That didn't show statistical significance though, because there weren't the population size, the sample size wasn't very large. But what they did see, which was significant, was that puree required more swallows to clear than the transitional solid or the functional texture. And the functional texture had significantly lower residue. And this is the residue levels in the oropharynx, the hypopharynx, and the epiglottic residue. This here is the number of swallows required. So with the functional texture transitional food, more often it required just one swallow to clear. So the finding is not that chewing causes lower residue, right? Because I mentioned before that functional textures elicit more chewing movement. But it's the finding that these different food tasks produce different downstream swallowing efficiency outcomes. And we don't understand why. Like at the time, we didn't understand why there would be lower residue with a functional texture. So in this study also, just to be clear, we didn't measure mastication, it's a fees study. So no tongue movement, saliva, or the state of the bolus before it reached the pharynx. So this is where the Cleveland Clinic is doing a study. And this is the question here in the study is diagnostic yield. So basically it's what I was describing before. So the patient getting that patient having that puree bolus and that really rapid swallow. And then you can see the mastication pattern that's happening with that transitional solid. And then with the shortbread cookie, you're just seeing more of that up-down motion. Of course, like I was saying, they're keeping it anterior and the tongue is kind of, in a sense, doing anterior posterior movement. Sometimes the bolus will go back and then they'll bring it back forward again. And so the question is whether if you change the food task, does that reveal different information about the same oral system? And really, it's not about going from 0 to 100. We're trying to find a middle zone so that we can see some oral capacity where the cookie might be asking too much of that patient all at once. And perhaps the puree is asking too little to reveal a lot of this, this oral phase potential. So the study is a randomized clinical trial, and of course it's a diagnostic yield study to say whether this trial of a transitional solid is going to help with understanding the impairments that patient presents with, and might even change their recommendations for the texture modified diet. So the arm group A was a standard modified barium swallow study with following the MBSIMP, where you have the liquid trials, the pudding, the barium pudding, and then a conventional Lorna Doone cookie cut to the appropriate size. The group B had the standard modified barium swallow study, but they added and it's Brian Hedman, who is just a wonderful person to work with, a great leader, and he's a PI on this study, and he's adding a coated, basically he's coating the high dissolving transitional so the trial goes between the pudding and the cookie. And so what we're looking at is the outcomes of the MBSIMP oral component scores, pharyngeal component scores as well, the oral transit and clearance, diet recommendation, and patient oral status variables. So basically, a lot of times people ask me, well, how do you coat the pudding on the savory's crispy melt? And basically, the way that Brian does it is he doesn't introduce the pudding until just when he's ready to introduce it into the mouth and present it to the patient. And he presents it on a spoon. So minimal manipulation, no fingers kind of like covering it, and gives the instruction to the patient to chew and swallow as they normally would. The same instruction that he gives for the Lorna Doone cookie. So, now here's some interim cohort characteristics that we found. You have the sample size is 24, the mean age is 66. We have a heavier male proportion and more Caucasian. Xerostomia was present in about half. High number had compromised dentition. 67% were intubated during admission, and 58% had a small bore feeding tube. So these were complex patients that were being seen. What's interesting here in interim results, we see that there was no difference between group A and group B as it pertains to the composite score for oral and pharyngeal. So far, we're not seeing a big difference. So this tells us, and we can interpret it, that group B, having the transitional food, was not a healthier swallowing group per se. And also, we're starting to see different things, that the transitional food starting to recruit more that masticatory pattern with fewer cycles than the conventional cookie. And so now we're digging deeper into those patterns that we can see. And so that's what brings me to this. The oral transit time is a secondary measure. But one thing is that the value of this is quite high, because the literature shows us that increased oral transit times is linked with the presence of dysphagia, longer meal duration, unfavorable nutritional prognosis, higher feeding burden, and energy costs. But there's no consensus on what is the range for oral transit time, what would be a normal range, what falls outside of normal, because it's quite complex. But what I'd like to say is that solids are a different beast than liquids. And so when we look at the definition of oral transit time, it's most commonly defined as the time from the onset of purposeful posterior lingual propulsion of the bolus to passage of the bolus through the oral pharyngeal boundary. So it doesn't include the time the patient spends collecting, chewing, compressing, and reorganizing a solid prior to that posterior lingual propulsion. So really, I want to preserve the oral transit time definition, but I want to introduce the concept of oral preparation as separate. And so in our study, we're going to look at oral preparation time, which is starts with the complete bolus contained in the mouth to endpoint of that onset of propulsive tongue movement. And so that's going to take into account that time, right? Because I feel like that time is quite valuable. And I would say the total time is the total oral handling time, and that is starts from the complete bolus contained in the mouth all the way to the complete passage of the bolus tail over the tongue base. And so that would include both the oral preparation time and the oral transit time. So I'm very excited to dig into that data. And so the other thing is mastication. We know that mastication is defined as repetitive mandibular movement coordinated with tongue bolus manipulation during oral processing. So what I'd like to say is that on MBSS, you cannot see, if you're just doing a lateral view, you can't see everything, right, with mandibular movement. But what we can do because we have to be sensitive to how much time the person is in radiology. Because if you had AP and lateral view, you'd get a better sense of it. But what you can see is a cyclic jaw opening and closing, right? So that can confirm mastication by the way you can masticate even in edentulous situations, right? You can show a masticatory movement. And the other thing is look at the condyles because if you see the condyles, you can see how they're moving. Are they just rotating? Or are they actually moving down? And that condylar rotation and translation is really telling you how much they're opening their mouth and how much that mastication is moving that bolus. So there's two different ways the jaw joint, and you have beautiful views of the jaw joint in that lateral view. So I think in our study, we're going to examine whether that OPT, oral preparation, oral transit time, mastication duration, we're going to look at chew cycles, oral architecture, and bolus outcome. So here's the domains, right? So masticatory motor pattern, the oral processing strategy. We want to look at that bidirectional oral bolus transport, especially in those edentulous or partially dentate population. So is this strategy different? And are we seeing this repeatedly across different patients? So it's basically how are they manipulating and controlling the food? Then the temporal demand, right? The time required, and the bolus transformation. So visible fragmentation, dispersed fragments. Where are the fragments landing to? So basically, my questions are with regards to oral processing, looking at the food properties, the dentition, the saliva, the tongue behavior, masticatory pattern. We went over all of that. We went over, the bolus, and really what we want to do is look at the amount, the fragmentation. Where is it located? Is it under the denture? Is it in the posterior folds? Like, where is this? Or if they're basically processing anteriorly, is it landing in the labial fold in the anterior zone? And so the pharyngeal response too. So the swallow timing, the residue, the number of swallows, and any airway invasion. So all of that is to say that oral processing matters because it can influence all three parameters. And so lastly, I just want to say, if the oral performance depends on the interaction between the patient and the food task, then I think that we're not simply asking, did they swallow this texture safely? I think we need to characterize the oral system, then choose a food that places a meaningful demand on it, observe how the system responds, and interpret what that response tells us about their capacity. And I'm calling that clinical reasoning orosync. And I'm happy to, that's going to come next as far as a discussion point in another presentation. So here is my email if you have any questions. The QR code is one that you can use to just an easier place for you to ask questions. It goes directly to a contact form page. So please use that, if you have multiple questions to ask. So thank you very much.
This is amazing. If we were live, I think you'd be getting a standing ovation. Thank you for your expertise. A couple of housekeeping items, and then we'll do just a few questions. Because there was a lot of great feedback and questions in the chat throughout the whole presentation. And I did link Dr. Bearwall's website in the chat for those of you who didn't see it. And I'll put it in Zoom as well because I know people were asking about transitional foods and just some of Dr. Bearwall's work. So I will put that in the Zoom email as well. But housekeeping items, the survey for ASHA CEUs will be provided via Zoom and it's in the chat. So just complete that within 7 days. And then if you'd like a certificate of completion, send us an email at tims-univ@tims.com. The recording of this webinar will be up on the TIMS website by tomorrow. So feel free to come back and check it out. There's so much great information. So I'm sure I'll be doing the same. And if you have questions about ASHA stuff, just send us an email at tims-univ@tims.com. All right. So with that, there's there was quite a few questions. I'm gonna pull up the Q&A quick. So this person is in Australia, but I did think that their question actually does apply to the US as well. They said, I work in aged care in Australia. I completely agree with your recommendations and thoughts on transitional foods. However, it's really hard to get aged care facilities to use and embrace these. Do you have any thoughts on how this is implemented in care within the US?
Yeah, so that's an excellent question because if we're getting right into transitional foods, the thing that I found, so I wanted patients to access it. I wanted patients to have this experience. And because I firmly believe if we can stimulate masticatory-like movements with a dissolvable solid, we can start seeing patterns. We can actually think of it as oral exercise, right? So like there's an exercise physiology aspect that Brooke and I talk about a lot that is really an important variable. So here's the answer. Dietitians. So what I discovered in the US was that this cannot be considered a snack. That will be the curse with your decision makers, leadership. And the reason is it's not a snack, right? Think of it as a dose dependent response. You want the person to be exposed to this behavior. And what I did is talk to the dietitians about it as a solid supplement. What that does is it moves it into a different category. It gets measured by nursing. They actually have to write I's and O's about supplements. So then you're actually seeing consumption patterns. The second thing is dietitians are noticing eating behavior changes. And what that means is more focus and attention on food. We know, and I didn't have a chance to talk about this, mastication improves focus, cognition, memory. It is incredible what we're seeing in intellectual developmental disabilities with transitional solids. Again, that's another conversation, but really try to focus on the dietitians improving intake, improve hydration. You're going to see versus a puree, you're going to see bite, chew, swallow, sip. Those are the patterns, which is a regular food pattern. So you are mimicking a regular food pattern while you're on a texture modified diet, which is very powerful for getting that patient to start from a neuroplasticity standpoint to start re-engaging with their meal. So I hope that that's helpful for everyone to understand eating behavior is a critical component to explain to the team.
There were a lot of questions and people asking, about including some of these items in MBS performance. So, would you mind just sharing how people can get in contact with you if they'd like to maybe incorporate savories into their MBS study? How would they start that process?
So it's kind of a tough situation just because we have to identify a workflow that would work for the team. And for a trial, you're only using one piece for a trial, right? So when you open the bag, it's good for 30 days. It's resealable, right? So you can dispense what you need and do it that way so that But what the benefit here is, like if you do a puree trial or you do a cookie trial, whatever, you do it at the trial, then you're giving a recommendation. What what the beauty of transitional solids, in particular crispy melts, is you're doing it during the study. If they perform in a way that is informative for the SLP, but also shows safety patterns similar to puree, and they have a pharyngeal impairment that you cannot take them beyond a puree diet. Why would you just study it during the MBSS? At that point, you want to continue to improve quality of life and dignity and have them continue it. So there's different strategies that you can assess in a modified barium swallow, but you want to be able to migrate that exposure to the room, essentially, to their patient room. So I'm happy to talk because their workflow is an important, you know, every single clinician wants something better for their patients. Every single clinician wants to have a new diagnostic tool that's easy and available. I think the biggest thing is operational workflow, making sure it fits within your team's workflow. And, you know, I help with educational materials for the entire team so that people are aware.
Awesome. Well, like I said, I know we can't get to everyone's questions because there were a lot, but I want to, one, thank you, Dr. Bearwell, for your expertise and time. There are a ton of messages just thanking you for this presentation. It was extremely informative, and people were saying, "Oh, I'd love another presentation on this topic and this topic." So, definitely be sure to check out her website and her work. She's done a lot of webinars and presentations in the community. So be sure and do that. Connect with her and connect her with your team to maybe explore how you can adopt this in your own practice. And then, like I said, if anyone has questions or wants to come back and watch the replay, I will have that up on the Tim's website. So with that, we'll go ahead and close out for this evening. Thank you all so much for being here, and we will see you later. Bye,
Thank
everybody.
you.